morning, everybody. Welcome to our weekly medical grand rounds, March 24th today. I'm just going to start with a land acknowledgement. Before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. And so with that, I'm going to hand it over to our Division Director and Section Chief for Pulmonary Medicine, Dr. Giovanni Ferrara.
Thank you, Narmin. It is a pleasure for me to introduce today Dr. Jason Weatherald, who joined our division exactly 1 year ago. So Jason is a graduate of the University of Alberta. He had his specialty training in Calgary, but the turning point of his career was actually European Respiratory Society long-term fellowship in Paris, in France, at the hospital L'Hôpital Kremlin-Bicêtre.
That's good.
Together with Marc Humbert, who is the world leader in pulmonary hypertension. I must say that looking at what Jason has achieved over the last year, I'm really amazed. Just think that he published his first paper in 2016-17. As of today, he has published 97 papers and is definitely the rising star internationally about pulmonary hypertension. So I can only be happy to have such a teammate in my division. But today, he will actually speak about something else, awake prone positioning for COVID-19. He co-led a multinational pragmatic trial on this topic that was published at the end in JAMA. And he also authored systematic review meta-analysis on the PMJ. So we are really at the edge of this topic. And welcome, Jason.
Okay, thank you for that introduction. It is really an honor and pleasure to be back home in Edmonton. Dr. Ferrara said I've been here for a year, and I'm going to talk to you today about a bit of an academic detour for me. As you said, most of my work has been in pulmonary hypertension and also clinically in lung transplantation since I've been here, neither of which are in any way related to this. So it has been a bit of an adventure. I will respectfully skip this since Dr. Kassam has already read it, and I will show my disclosures here. So the objectives of my talk are to understand the physiologic and clinical rationale for prone positioning during the COVID-19 pandemic. And secondly, to understand the current evidence and the remaining uncertainties for implementing awake prone positioning for patients who are not intubated and mechanically ventilated. So I realize we have a very diverse audience, and I'm going to go way back for many of you to this key text, the Respiratory Physiology Essentials by Dr. John West, just to review some of the mechanisms of hypoxemia. So there are five. Number one is low inspired oxygen, which is really just present at high altitude. Hypoventilation, which is due to not breathing enough with high PaCO2. Right to left shunts, such as intrapulmonary or intracardiac shunts. Ventilation perfusion inequality, which if you're being grilled on rounds is almost always the right answer, and then primary diffusion impairment. So when patients have hypoxemic respiratory failure, it can be any one of those mechanisms. And in people with pneumonia, it can be different mechanism depending on the presentation. So on the left, you have more of a lobar pneumonia with a dense consolidation in the right upper lobe. And this is a more extreme ventilation perfusion mismatch where there's no ventilation going to this lobe, but there may be some perfusion, so that results in shunt. However, in the acute respiratory distress syndrome, typically you have a picture like this on the right, which is bilateral airspace infiltrates, which is symmetrical, and this is an extreme ventilation perfusion inequality. So the acute respiratory distress syndrome is a syndrome with clinical characteristics that has many potential causes. And the Berlin definition of this requires that a patient has bilateral opacities on their X-ray. They have hypoxemia defined as a ratio of the PaO2 to the fraction of inspired O2 of less than 300. And it cannot be, and it's not due to left heart failure, because pulmonary edema from congestive heart failure can look the exact same way. And it typically has onset within 1 week of some sort of insult, many of which are outlined here on the left. There can be central nervous system injuries, inhalation injuries, aspiration, the most common being infections, particularly viral pneumonias, trauma, and intra-abdominal sepsis. So many conditions can lead to ARDS. So stepping back, why is prone positioning useful in ARDS? Well, this has actually been used for many, many decades, and it was first proposed in the 1970s to improve gas exchange and improve oxygenation in patients who are mechanically ventilated. And this is because here on the left, you see a CT scan with the heart and the lungs in a supine patient. And when a patient flips over onto their stomach, you have a change in sort of the strain on the alveoli in the lungs, which becomes more homogeneous. You also have the heart is now sort of based on gravity lower down, and the weight of the heart on the left lower lobe is removed. So it improves atelectasis or compression of the left lower lobe and improves ventilation perfusion matching in that part of the lung. And so really this triangle diagram helps to illustrate it here. So when you're supine, you have variation in alveolar size. So the dependent dorsal regions of the lung are smaller and more squished. And when you are in the prone position, this is more uniform. And this does improve oxygenation, but really the main thing that this does in mechanically ventilated patients is help prevent ventilator-induced lung injury. I'll get back to that later. So these are the potential mechanisms as to why lying in the prone position might be useful in ARDS in mechanically ventilated patients. So it does improve oxygenation through the mechanisms I talked about with improved ventilation and perfusion matching here. But also when you're prone, you can improve secretion clearance because you have gravity sort of helping and facilitating secretion drainage, so you get less plugging of the larger airways. But probably the main mechanism is this reduced ventilator-induced lung injury, but also because it improves oxygenation, you have improvements in hypoxic vasoconstriction, and you may have a reduction in intrathoracic pressure, which helps offload the right ventricle. And so this was used for many years, but didn't have really robust evidence in terms of how it affected outcomes until this trial, which is called the PROSEVA trial, which was a multi-center randomized controlled trial of intubated patients with moderate to severe ARDS. And that was defined as a PaO2 to FiO2 ratio of less than 150 on at least 60% oxygen. So these are really sick patients. And they randomized 466 patients to prone positioning or standard positioning or control. And the primary outcome in this trial was mortality at 28 days. And this was the main result of that trial. You can see here in the Kaplan-Meier curves that there is a significant improvement in survival in patients who underwent prone positioning. The absolute reduction in death in these patients was 16.8%. And that translates to a number needed to treat to save one life with moderate to severe ARDS of 6. So a really effective intervention in the ICU in mechanically ventilated patients. So that's kind of the background, but I want to take you back, and if you can just kind of close your eyes and remember what early 2020 was like, there was a lot going on. Here are some of the headlines from January to March of 2020. So it was a high stress time in our lives. And you can see as things got worse, we could see that this pandemic was emerging. China was locking down cities. There was increasing number of cases in New York, then in Europe, in countries like Italy, Iran as well. And pretty soon the entire world locked down. This is what we were seeing in the hospital, and this is what COVID-19 looked like. So it's, radiographically very similar to other causes of the acute respiratory distress syndrome. You have here a relatively moderate case where you have bilateral ground glass opacities shown here, and some areas of more dense consolidation, which is generally worse in the dorsal and dependent regions. In the lower panels, you see a more severe case where you have really dense airspace disease here in the dependent regions with ground glass and septal thickening. If you recall at the beginning of the pandemic, in some countries that, had this happen before things really hit here in Canada, there was really an unprecedented strain on critical care resources, including many places that were running out of ventilators. They did not have enough ventilators and enough staff to save these people. And this is from a really I would say, really moving editorial from 2020 in the New England Journal from a group of doctors in Bergamo, Italy, which is around Milan. And what this graph shows is their baseline ICU capacity here in the green lines and the number of patients with COVID-19. And you can see what happened. They went from an ICU in this hospital of 10 beds rapidly to 90, but they capped out. They ran out of resources. And this quote here at the bottom is from that article. When the ICUs began to overflow, some less sick patients had to remain home, or several of them died. And so I'm telling you this because this was really some of the rationale to doing some of these unconventional interventions to try to preserve and delay the need for intensive care resources in the early pandemic. And I think many of us kind of felt like this. We felt like this big tidal wave was coming. We had a lot of notice here in Canada. We had time to prepare. We had time to institute public health interventions while we watched the rest of the world getting hit with a massive tidal wave. And in the early pandemic, while we waited for this, I admittedly spent a lot of time on Twitter, but I was following people in Italy and in the East Coast, and we saw people reporting things like this about using prone positioning in non-intubated patients, awake patients with hypoxemic respiratory failure. And this was a pulmonary fellow actually from Baltimore at the time who was talking about, and I circled here the date, this is late March 2020, saying that our experience in COVID-19 patients has been similar. While in the early stages of data collection, prone positioning in patients not mechanically ventilated seems to improve oxygenation, tachypnea, and dyspnea. With a looming shortage of vents, prone positioning with high flows nasal cannula is a possible strategy to avoid intubation and its complications in patients with moderate to severe ARDS, but more data is needed to assess its safety and efficacy. Again, I remind you, this is the very beginning of the pandemic. And I found it interesting, this comment from someone on Twitter that said, that explains why when I am coughing at night, I roll onto my stomach or side and I feel better. So there was already some thought based on physiologic principles that this may be beneficial. So here are the potential benefits that were thought of in terms of awake prone positioning for non-intubated patients. So it could improve oxygenation or O2 sats, as well as VQ matching based on those physiologic things I talked about. But potentially this could avoid or even delay intubation and mechanical ventilation. And if you can avoid mechanical ventilation, you avoid all of the other bad things, not bad things, but complications that come with it, like sedation, neuromuscular blockade, ventilator-induced lung injury, critical illness, weakness, and potentially you could improve survival. So there was a strong rationale to start looking at this. But this was the evidence at the time, and we did a rapid review in early 2020 to look at the evidence, and there were very few studies looking at non-intubated patients and implementing awake prone position. And really these were small case series, mostly of patients with viral pneumonia. And you can see that the rate of intubation in these observational studies was ranging from 13% to 45%. So really not much evidence to guide us at the time. Because we were seeing this and thinking about this problem, we tried this in a few patients in Calgary, where I was at the time. We looked at consecutive non-intubated patients, 17 patients, 12 of whom were in the ICU, 5 on a regular ward between April and May. These patients generally could do about 1 day of prone positioning and 2 sessions with a duration of laying in the prone position of about 75 minutes, so not too long. These graphs here show the improvements, however. So SpO2 to FiO2 ratio is kind of like a non-invasive way of measuring oxygenation. It's how well are your sats given a FiO2 that's administered. And this shows the individual patients in the supine position. And as this, a higher number is better. So as they turn in the prone position, most patients improve their oxygenation. But when they return to the supine position, in most people, it went back to where it was before. So it's not really a sustained response. It's a transient response when you're lying in the prone positioning. However, if you look at respiratory rate, which is kind of a surrogate for work of breathing, you can see that patients also improved. So many of these patients were fairly tachypnic and their respiratory rate went down in the prone position, but then returned when they went back to the supine position. This is from a study in Italy that shows really the same thing, but these are patients who were on non-invasive ventilation while doing prone positioning. So these were people on BiPAP. And this is kind of interesting because you see their saturation here on the y-axis. These patients went, this is before prone positioning, then they proned, And when you're on non-invasive ventilation, it seems like on average, patients were better than when they started, probably because you recruit some of that lung and it remains recruited when you're on some positive pressure ventilation. And similarly, there's a very, in some patients, quite a marked improvement in the PaO2 to FiO2 ratio and a decrease in the respiratory rate, which was sustained. So that's great. It improves oxygenation, but does this actually improve clinical outcomes? And we were part of our group that was part of this AHS Scientific Advisory Group Rapid Evidence Report, which asked the question, in awake non-intubated patients with SARS-CoV-2 pneumonia who are being cared for in acute care facilities, is prone positioning safe and or effective in improving patient outcomes? At the time, there was little evidence, and while it may be used to improve oxygenation and saturation levels, its effect on clinical outcome was completely unknown. Okay. So there was really no evidence that it improved survival, reduced intubations, or need for ICU. Furthermore, the adverse effects and potential risks of this intervention were not really well defined. And I must say, at the time, there was a lot of disagreement about whether we should be doing this. Some people said, well, it's probably not harmful, everyone should be doing it. But there was a camp of us that really said there's truly equipoise in this question. There's really no conclusive evidence that this is helpful. And it caused some disagreements between people because, based on the belief that this should work, if you improve saturations, it's probably a good thing. There are some potential safety concerns here. So you may be just delaying the inevitable, delaying intubation, which could actually cause a more emergent situation when you do have to intubate a patient, and may actually worsen their outcomes after they ultimately get intubated. So maybe you're not actually helping these patients at all, other than buying more time or delaying intubation. There is also the possibility of causing hemodynamic instability when you prone patients. You can accidentally remove urinary catheters or vascular catheters. It can put pressure on the stomach, so patients may aspirate. It could also cause, if you're prone for a long period of time, can cause pressure ulcers. And there's also a theoretical risk of cardiac arrest. But again, people were arguing, well, what about this very compelling SpO2 saturation improvement with prone positioning? But really importantly, improvement in oxygen saturation does not equal an improvement in clinical outcomes. And this has been shown in several other interventions, largely in the critical care population, where you can do things that improve oxygen, but they make no difference on long-term outcomes. That includes things like using hyperoxia, inhaled vasodilators, and certain mechanical ventilatory strategies. So just improving SATs does not mean you're actually going to help that patient's ultimate outcome. And some of the support for that statement actually comes from this post hoc analysis of that randomized trial that I showed you of prone positioning in intubated, mechanically ventilated patients with ARDS. So they looked at whether or not the improvement in gas exchange when you put patients in prone position actually predicted the outcome in that trial. And in fact, the increase in survival seen in patients who received prone ventilation in the PROSEVA trial did not depend on whether or not their gas exchange improved. And what this really supported was that the mechanism of improved survival in mechanically ventilated patients was actually due to ventilator-induced lung injury and sort of reducing the damage that high ventilatory pressures cause to the lung. And that more homogeneous distribution of mechanical ventilation pressures in the prone position reduces the damage that's being caused by being on a breathing machine for a long period of time. So it's really not about the improvement in saturation. So again, this sort of is some suggestive evidence against why awake prone positioning may even help clinical outcomes. And so to answer that question, we developed this awake prone clinical trials program. And this was a collaborative effort between investigators at McMaster in Saudi Arabia and at the University of Calgary. And we had sites across Canada, some in the US. And our questions were, does awake prone positioning actually prevent intubation, or are we just delaying the inevitable? Does it actually improve survival? Or could this even be harming patients because of that delayed intubation? And so we designed parallel trials of patients with suspected COVID-19, and we based the screening and enrollment on their goals of care. So in patients who would accept intubation, they went into the COVID-prone trial. And for patients who do not intubate goals of care, we screened them for this Corona trial. And the design was very similar, but the primary outcomes were different. So the primary outcome here for COVID-prone was intubation, because these patients would accept intubation, but of course that's not really a relevant primary outcome for patients who say, I don't want to be intubated. So those patients would be screened for the Corona trial. I'm going to talk mostly about Coviprone because this is published in the Corona trial in the do not intubate patients is not finished or published yet. So the primary objective of Coviprone was to determine the efficacy and safety of awake prone positioning in patients with hypoxemic respiratory failure due to COVID-19. Again, this was a multinational randomized controlled trial. It was pragmatic in design. We had centers in Canada, the United States, Saudi Arabia, and 2 in Kuwait. Here are the eligibility criteria. So these were focused on adults who had suspected or confirmed COVID-19. And I will say in the end, because PCR testing was available, 99% of these patients had confirmed COVID-19. They had hypoxemia and they had to be on at least an FiO2 of 40% or 5 liters per minute by nasal cannula. And they had to have abnormalities on their chest x-ray. And they had to be in a setting such as an intensive care unit or a high observation unit or like acute care unit where hemodynamic and respiratory monitoring was feasible. And so we did perform this on many just general medical COVID wards. The exclusion criteria were important. So patients who were in respiratory distress who needed emergent intubation were excluded. Those with decreased level of consciousness, those with any contraindications to proning, which really included decline of the patient or substitute decision maker, hemodynamic instability, BMI over 40, certain skeletal deformities that would make prone positioning uncomfortable or dangerous, pregnancy, and those who would not accept intubation. Also, patients who had been proned already based on the treating physician for more than 1 day prior to randomization were not eligible. And our intervention was this awake prone positioning, which was patient and nursing unit driven for a target of 8 to 10 hours per day. And this was kind of our best guess at the beginning. We didn't have a lot of data to guide us about our intervention. And patients in the usual care arm were specifically instructed not to prone. Of course, this is an unblinded intervention. Patients can read stuff on the internet. And so in some cases, patients could still prone if they felt like it, if they were more comfortable. So the patients were randomized 1-to-1 to either of these groups, and we stratified them by the severity of hypoxemia. And these were the main outcomes in Coviprone. So as I said, the primary outcome was endotracheal intubation at 30 days, and our secondary outcomes included mortality at 60 days, invasive ventilation free days at day 30, ICU and hospital free days alive at 30 days, adverse events, and here's what happened in the trial. So we screened 4,000 patients and 400 were randomized, 205 to awake prone positioning and 195, sorry, this is an error. This should be the control group here. Pardon me. So, and we did an intention to treat analysis. And here's what the patients look like. So the mean age was about 57 years in both groups, predominantly male, as is consistent with what we know about hospitalized patients for COVID-19. The average BMI was about 30, and most patients were in hospital for about 1.5 days until they were randomized. They were pretty sick patients. So the SpO2 to FiO2 ratio, the majority of them had a ratio less than 150, which is pretty severe. And the median SpO2 FiO2 ratio is 130. That translates to a inspired oxygen percentage of about 70% O2, which if you've worked on any of the wards, that's quite a bit of oxygen. And almost 3/4 of the patients were on high flow nasal cannula, and about, there was a bit of imbalance here, but 12% in the awake prone group were on non-invasive ventilation, such as BiPAP, and 20% in the control group were on BiPAP. Here's how the patients did. So again, our goal was 8 to 10 hours per day, but the median duration of adherence to proning was 5 hours in the intervention group and 0 hours in the control group. So we did get reasonable separation between the groups, and that was sustained across the first 4 days in hospital, but started to decline by day 4. But you can see that there were some patients here in the control group that did prone. And here's the main result in terms of the primary outcome. So there was statistically no difference between the two groups in the rate of intubation. 34% of the patients in the prone group got intubated and 41% in the control group got intubated, with a hazard ratio that was 0.8, but was not significant with confidence intervals overlapping 1. There was an estimate of an absolute reduction of about 6% in intubation, but again, confidence intervals that are quite wide that overlap 1. And here's the curve for mortality. So here we have increasing mortality over time, and you can see that there's statistically no difference between these two groups. The mortality was 22% versus 24%, with a hazard ratio and absolute risk that was non-significant. In terms of our secondary outcomes, none of these were significant either. The effects were not really marked, and there was really no convincing evidence that any of the secondary outcomes were improved. Fortunately, it was quite safe. So overall, there were very few adverse events related to proning. So 10% of the patients in the proning group had minor adverse events. None of them were serious. Overall, there were 26 adverse events out of the 400 patients. Most of them had to do with pain or discomfort when they were lying on their stomach. Some people who paradoxically desaturated in the prone position, and a few patients who had accidental removals of intravenous catheters. The main limitations of this trial, though, are, as with all of the trials in this area, were that the intervention was unblinded. So there was a bit of crossover. Patients in the control group could prone if they felt like it. And again, there were some clinicians that came through that strongly believed that proning worked. And so they would just tell patients in the control group to prone, which was a protocol deviation, and ultimately would tend to make the effect size smaller and bias the groups towards the null effect. Also, there's some imprecision there. Again, the results are suggestive that this might work, but the confidence intervals were wide, and we probably could have used another 100 patients in the trial. But estimating a sample size for a clinical trial when you have absolutely no idea what the effect size is, because there's no prior data, is actually pretty hard to do in reality. But the key messages from this trial, which was published in JAMA about a year ago, were that awake proning for long hours is actually pretty challenging for patients, and there was no effect on intubation or any secondary outcomes. However, it was imprecise in our effect estimate, and it did not exclude a clinically important benefit because of the trial ultimately being underpowered. Okay, so is that it? Doesn't work. Well, not exactly. So we weren't the only people that had this idea. There was another publication that came out before COVID-prone in the Lancet Respiratory Medicine, and we were honored to write the editorial, and I think maybe my most clever editorial title that I've thought of. But this was an interesting approach. So at the beginning of the pandemic, it was really hard to put together these multinational clinical trials. There's obviously, when you're starting clinical trials, especially in a pandemic, there's major delays in things like ethics and contracts and data sharing agreements. And so what this group did is there were 6 different groups that were running kind of their own idea trials in their countries. And as they started, they kind of harmonized their protocols and tried to do everything as similarly as they could, with an agreement to prospectively meta-analyze their data. So they called this a meta-trial, and it's really not a single trial, it's a prospective meta-analysis of very similar trials, which is an interesting concept that I had not really heard about before. And they managed to randomize 1,000 patients, or 1,100 patients, 567 to prone positioning and 559 to standard of care. And in their meta-analysis, or their meta-trial, they did find a significant reduction in intubation, and their effect size was quite similar to what we saw in COVID-prone in terms of its magnitude. It reduced intubation by about 25%. But similar to us, they had no signal of an effect on mortality. What's important, though, I think, is to look at the individual trials in this meta-trial. So really, there were a few trials that recruited almost no patients. So there was a few sites in Quebec that participated in this trial and not our trial. There was a site in Ireland and a site in Spain that put in, in total less than 100 patients. But there were 3 bigger trials, one in France, one in Mexico, and one in the United States. And the trial in Mexico on its own was significant. And this was a big trial which really drove the results of the meta-trial. So you can see the effect sizes in the other trials are really quite small and in most cases non-significant. The important thing about the Mexico trial is that they did a really good job of proning. So this is the mean and median duration of adherence to the intervention, and they did much better than we did in COVID-prone. So they were able to get about 8 to 9 hours of proning. And this trial was mostly done in the intensive care unit. So some of the explanations for that is that they had 1-to-1 or 1-to-2 nursing and a lot of encouragement. And I think it might also have to do with sort of the structure of the medical system and how they were able to really encourage these patients, perhaps because there were not a lot of other options at the time. So there's that meta trial, there's our trial, and there's actually a few other trials. So in order to really get a better picture of what the evidence is, we did this systematic review and meta-analysis, which was just recently published in December. And we looked at randomized controlled trials, including were cluster randomized trials, and quasi-randomized trials, because we were aware there was one out there. And we looked at only trials that looked at hospitalized patients with hypoxemic respiratory failure due to COVID-19, and they had to compare prone positioning to usual care or no proning. And the groups had to be otherwise similar in terms of their care. And they had to report at least one outcome of interest to be included. The primary outcome of the systematic review was intubation, because that was our main question. But we looked at all of these secondary outcomes in the trials, including mortality, length of stay, ventilator-free days, whether or not patients escalated their oxygen modality. So that would be patients that went from regular oxygen to high flow, or from high flow to BiPAP, and any changes in oxygenation indices, as well as adverse events. We looked at risk of bias using the Cochrane risk of bias tool version 2, and we did some different analyses. So the primary analysis was frequentist, or the traditional way of looking at a meta-analysis and pooling data. But we also did a secondary Bayesian analysis, which I'll talk about later on. We did a trial sequential analysis, which sort of looks at the accumulating data as trials came out, and also some subgroup and sensitivity analyses. And then we looked at the overall evidence for each outcome and applied the grade method for assessing the certainty of the evidence for each outcome. And so this is our Prisma diagram. So we screened over 2,500 articles, and we identified 17 trials. That was in 12 papers, because that meta trial reported 6 trials in one publication. And here's the primary result here. So in terms of intubation, the pooled analysis of these randomized controlled trials did find a significant reduction in intubation, with a effect size, a relative risk of 0.83, which was significant. And we rated the quality of that evidence as being of high certainty. And this translates to preventing 55 intubations for every 1,000 patients prone. So significant, but a small effect overall. Again, in terms of mortality, there was really no conclusive benefit that this translated into improved survival. Again, the effect was on the side of being favorable. There was no real convincing signal that this was harmful, but the confidence intervals overlapped one. And just briefly, these are those secondary outcomes, and really none of them were significant. And the quality of the evidence was, or the certainty of that evidence was lower to moderate. Not all of the trials published or reported each of these outcomes. So next, does anyone know who this guy is? No? Okay, this is a guy named Thomas Bayes. He's an English theologian and statistician who came up with Bayes' theorem, which is about it's a probabilistic theorem that was really never recognized until well after his death. But Bayesian analyses are a bit different than our standard frequentist analyses. So Bayesian analyses combine what you know before, so your prior assumptions about or beliefs about the effect of an intervention, with the evidence that's accumulated through the process that guides your statistical inference. So the key differences here is that it really uses prior information available from the previous studies into the analysis, and it determines the probability that your parameter, such as an effect estimate of an intervention, would end up being in a certain range. So it's a different way of looking at the data, and you can sometimes get different conclusions depending on which you apply. A frequentist, where we have this canonical p equals 0.05 thing, and that's the threshold something is positive or negative, where Bayesian analyses can give you different scenarios depending on how strongly you believe something works beforehand. So I'll walk you through what the Bayesian analyses show. So you have to pre-specify your prior beliefs, and you can do something that's non-informative or neutral, and effectively this gives you the same result as what a frequentist analysis is. So this means you don't really think one way or the other that an intervention is going to be beneficial. Or you can enthusiastically believe that this is going to be an effective intervention. These are the people that say prone positioning works no matter what. I believe in this because I've seen it happen. We base this on a meta-analysis of observational studies. So this was the approximate effect size in observational studies. Or you can be more skeptical about the intervention. So you can say, I don't think this is, I'm a little bit skeptical, but it might work, it might not work. A minimal skeptical prior would be an effect size such as this, and this was based on the confidence intervals of that previous medical analysis. Or you can really think, I don't think this works at all. I believe that this is probably not going to work. And what happens is you get different average effect size estimates based on your priors, given the data that we saw in the meta-analysis. So it's kind of like your likelihood ratio tests, right? Where you take your pre and your post-test probability. So we apply the data from the meta-analysis, and these are our posterior probabilities right here. So the way you look at this is that this is the probability of at least a 5% reduction in intubation based on your baseline assumptions. So if you have really no compelling opinion about the effect of the intervention beforehand, there's still a 96% probability that there's at least a 5% reduction with awake prone positioning. If you're enthusiastic about it, it's almost 100% probability that this thing works by at least a 5% reduction. And even if you're skeptical that awake prone positioning doesn't really do anything, there's still a 90% probability that it reduces your intubation rate by at least 5%. And the other columns here are just the inverse. It's like these are the probabilities that there's actually harm based on the data across a spectrum of assumptions. So really, there's almost no potential chance that awake prone positioning is harmful based on the data. However, when we look at mortality, the confidence or the credible intervals here overlap one in almost every scenario, except for unless you enthusiastically believe that proning reduces intubation. So in that case, the chance of a 5% reduction in mortality is really only high if you're enthusiastic, if you strongly believe that it worked. But if you're a bit skeptical, the chances that it reduces mortality is quite a bit lower, with probabilities of 73 or 47%, so not very high. Okay, so one of the questions that had come up frequently was, does it really matter how long you prone? And that it would make sense. Like, there should be a dose response. Like, the longer you can do it, maybe it's the better. And we tried to explore that in our meta-analysis, but we were only able to do that at the trial level. So most trials reported how long patients were able to adhere, and we stratified them by whether or not people in their trial did 5 or more hours or less. So this pooled analysis does suggest that there's a bigger effect in trials that had longer durations of proning. However, when you compare these two groups, they're not the same kind of patients, and so you have to do interaction tests, and the interaction test was actually not significant. So that while this is suggestive that longer proning is better, it isn't really conclusive. And this graph here is what's called meta-regression. So we looked at kind of the effect size at the trial level versus the time that the trial spent in the prone position. But there was also not a clear relationship between duration of proning and effect. So this question remains a bit unclear. And so this data informed a recent clinical practice guideline about using awake prone positioning in COVID patients. And really the recommendation at the end was that in non-intubated patients with COVID-19 and acute hypoxemic respiratory failure, regardless of different oxygen supports, they did recommend a trial of it if feasible, which was a strong recommendation based on moderate certainty evidence. But they highlighted here that it's really unclear whether this works better in sicker patients or less sick patients, and whether or not longer proning is better. So based on what we know now, what are the gaps in future directions? And I would say that which group of patients benefits remains quite unclear. It's not really clear. And I think the best way to answer that would probably be individual participant level meta-analysis, like pooled analysis using individual patient data, where we can actually look at whether or not time in prone positioning modifies the effect. Is there a minimum or optimal duration of proning for benefit? That we also don't know. And I think really importantly, if COVID ARDS is a thing of the past or relatively infrequent going forward, does this intervention, do all of these results actually apply to other causes of hypoxemic respiratory failure and ARDS? That we also don't really know. And importantly, most of the trials and most of the patients in our trial were pre-vaccine, and it's not really clear whether these results are still applicable, whether the nature of the disease is the same. And I think those of us that still practice in acute care, we see a lot fewer of these patients. So, most of the people coming in with severe ARDS are severely immunocompromised, and it's really not, there was a very small numbers of those patients in our trials. And in terms of implementation, especially outside of a surge where we have organized COVID units, it's not really clear how best to implement this intervention and where to do it. Like, should this be patient-led versus nursing unit-led? Should it be done on regular wards, or should this only be done in high observation units versus the intensive care unit as kind of a salvage therapy? So in summary, I would say this is a bit of a diversion in my academic career. We took a completely different path for the last 3 years, but it was a really interesting learning experience in terms of learning how to do pragmatic clinical trials, as well as different research methods. But in conclusion, I would say that this is a safe, non-pharmacological intervention for patients with ARDS due to COVID-19, which does improve oxygenation and probably reduces the need for intubation in certain patients, but doesn't have a clear effect on other clinical outcomes. So it should be considered in patients when they do present with hypoxemic respiratory failure due to COVID. And clearly further research is needed based on what I've told you to understand that who really benefits most and how we should implement this intervention, if at all. And just to conclude, I wanted to highlight this quote from that same New England Journal of Medicine letter from the group in Bergamo, Italy, that says, "We acknowledge the many brave and committed physicians, nurses, and other hospital staff who work tirelessly through the events reported here." And I encourage you to read this. It's a really somber description of what happened. And I will say there's a lot of revisionism going on about what happened during the COVID pandemic, but in the very early days, this was a very real thing, and a lot of people died, and there were some very heroic things done by people in Italy and on the East Coast who informed the research that we did. So I'm also grateful for all of the staff in Calgary that and across the sites that worked on this trial with us. And here are some of the people on our group I just wanted to acknowledge before it's over. This is Walid Al-Hazani from McMaster, who is the lead investigator, and Ken Parhar from Calgary, who's a critical care physician. Zainab Al-Duhalab, who was a fellow at McMaster and is now back in Saudi Arabia, who helped design the protocol for the trial. Professor Yassine Arabi is from Saudi Arabia, who led the recruitment there, and they recruited about almost a third of the trial in COVID-prone. And then the other two lead applicants were Tom Stelfox and Deborah Cook from Calgary and McMaster, respectively. So it was a huge team and a really great group to work with. And that's it. Thank you.
Thank you, Chris. That was a very, very nice presentation. And, listening to your presentation, I thought, we very easily forget sometimes about the very bad things that we went through, because at the very beginning of the pandemic, there was a phenomenon called hypoxemia. That was the real problem, that patients just fainted away, right? So I can tell you that in places like Italy, having the possibility to delay an intubation of a day or two was a big thing.
Mm-hmm.
So let's say we have a few questions here. So Dr. Armstrong, enjoyed your really insightful presentation. Great to see physiology come alive in your work. Would you not agree that your sample size may well have underestimated the treatment effect of your primary outcome? Let's start with this first.
So it may well have underestimated. Certainly, I mean, if you look at the confidence intervals, there could have been a huge effect. The assumption in the sample size calculation was a bit ambitious. I believe it was 30%. We hypothesized a 30 or 40% reduction. And part of that is grant gamesmanship and trying to make the trial sound feasible. And based on the observational data, that was the effect size that was suggested, although probably a bit optimistic. So ultimately in our meta-analysis, the effect size when you pooled all of the trials was identical to what we saw in the COVID-prone trial. So it actually ended up being a pretty good estimate of reality, I think.
Yeah, and the question continues with the problem of heterogeneity, which I think you also addressed during your presentation. Obviously, BMI and other characteristics were also.
Yeah, that's a great question, and that's something that we discussed in detail in our editorial of the meta trial, because we didn't randomize the duration. So the duration was driven by patient factors. So it may just be that younger, fitter, less sick patients could do more prone positioning, and that mediates the relationship between duration and the outcome. And so there's not a great way of exploring that at the trial level. That's what individual patient level data would allow us to do. And that is in process right now. The multiple groups are working on agreements so that we can explore that question a bit better. It may very well be that factors like BMI made it harder to remain in a prone position, and that was more likely to result in them getting intubated. So it could be confounded by several things.
Let's see what Dr. Kassam has hands on.
Thanks, Jason. What a great presentation. For those of us who were working on the wards, and as this information was coming out, this was one of the areas that it was nice to know was actually being studied, because there was just so much anecdotal information, both on social media and various forums that was being thrown around. But my question is going to be similar to the last bit that you talked about in terms of other factors. There were a number of patients, as you said, who may have been in the control arm, actually subjectively felt better being prone. And so I wonder if there was any sort of qualitative information that was gathered, and it may have been that, it was, body habitus or whatever that just made them feel better. But I remember there was a point in time where we were worried about the harms outweighing the benefits, with IVs coming out and all the rest of it. But there were patients just felt better. So you said, okay, well, feel better, go for it, as long as there's somebody who watches you when you're turning and all the rest of it. I wonder if you can comment on that.
That's a really great question, and certainly that was my experience too. Some people really did feel better, whether or not their SATs got better. We might have a bit of data on that from the sister trial, the Corona trial, which is not really done being analyzed yet or reported. And that trial was incredibly hard to recruit for. It was in DNI patients, so they were really sick. Many of them were delirious and just couldn't consent or actually do the intervention. But we do have some qualitative data in terms of comfort and symptoms in the patients that did get in that trial. So we will eventually have some of it in that group. But for COVID prone, it was like logistically way too hard to get patients to do surveys. There was a study done in the States where they tried to use a smartphone app to also encourage patients to do proning in their trial, but also to record some of that qualitative data. I don't recall what ended up being reported in that paper about the qualitative effects, but I would say anecdotally, I had the same experience. Some people just said, yeah, this is way easier. And that is, I think, a physiologic and mechanical explanation for it. It's just the work of breathing was less in the prone position. Particularly, I would say BMI may play a role in that. Patients with elevated BMIs may not be as comfortable in that position because of sort of the pressure in the abdomen pushing the diaphragm up. So that's, again, just physiology and experience based. I don't have good data to support that statement, though.
Great presentation. Thank you.
Thank you very much.
I was also thinking that obviously the way we treated COVID, that we're treating COVID today, evolved significantly in a very short time, right?
Yeah.
So there might have been also a confounding effect of the treatments. We started with hydroxychloroquine, we end up with tocilizumab and dexamethasone, right?
Yeah.
I mean, I wonder if giving anyway some time to the patients, even just a few hours before intubation, would have helped to clear up infection, the viral infection.
Yeah, and that was what we were hoping. And fortunately, the way the waves came and the recruitment happened in COVID prone is there was a lot of recruitment in Saudi Arabia in the first wave before we knew that corticosteroids worked. But most of the Canadian recruitment happened in that fall wave in September, and we kind of were already hearing about the data from that UK trial that showed that corticosteroid worked. So when we looked at the end in COVID prone of the 400 patients, the vast majority had received corticosteroids. So I do still think that the results are reflective of the modern treatment environment, where that is probably our most effective therapy plus tocilizumab. But it is mostly pre-vaccine data. So again, I don't know how that would explain or change what our conclusions are. But yeah, the area evolved so rapidly in the first 6 months that it was really hard to keep a handle on everything.
Yeah. Okay, we have the last comment from Dr. Wack. So Bias was a minister of the church, and this probabilistic method of analysis didn't change his opinion about the existence of a God. He was very optimistic, I believe.
I think he was enthusiastic about it. His priors were enthusiastic.
Dr. Levin.
That was a great presentation, Jason, and complex problems, all kinds of confounding and such. Question for you, have you ever slept in a hospital bed?
Oh, yes, in this hospital.
Have you ever prone in a hospital bed? I guess one of the thing I'm alluding to is, are you aware of any kind of biomedical, mechanical interventions to try and make, you alluded to ICUs or observation, one-to-one nursing, et cetera. I wonder if there's any kind of biomechanical intervention that might make proning more successful. People would be able to prone for longer periods per day. Are you aware of anything like that?
Can you repeat that?
Yeah, I'll repeat the question. So Dr. Demant's question was, are there any sort of biomechanical ways to facilitate prone positioning because of, and particularly in hospital beds, that being an uncomfortable way to lie when you're sick? And I don't know of any actual evidence, but certainly a lot of people did. And there's videos on YouTube that we would refer patients to that would show them different ways to get comfortable, either putting pillows under their knees or sort of under their stomach to sort of make them take some of the strain off of their lower back. So there's all sorts of things. And in the ICU, they use all kinds of ways to try to make patients more comfortable and actually turn them safely. So they have, during the pandemic, they had these proning teams that would go around and rotate patients in the ICU, the mechanically ventilated ones daily. And it's, I think there's a lot of research on how to make that more comfortable and feasible to avoid also the complications that can happen in people that are proning for a long period of time, like pressure ulcers. So beds that sort of vary the pressure may help prevent some of the complications.
Thank you, Jason. This was a
Great.
great presentation.
Thank you.
Thank you very much.